Hi, everyone. Um, Not sure how many we are, but I'm looking forward to tonight's webinar. We'll be doing the level 2 of the master's program tonight, and I'll also be joining you mid May, I believe, or more in the later part of May, the third week of May, where we're going to do the third part, and I'll be doing that one as well. So I'm just, Tara, should I wait just a little bit more? Are the people bunching in? Because I'm not able to see any of that.
Yep, they are. They're filed in, it looks like. I think everybody's in. It looks, I don't see any new names popping up, so you could take it
Okay,
away whenever you're ready. Thank
wonderful.
you.
Wonderful, thank you. All right. Well, tonight's what we're going to talk about is mastering the basics of dental implants. There is going to be. I was on Karen Young's conference last month, and I was great conference. Obviously, Karen, if you're on, congrats. It was an amazing as always. And what you're going to see going from Karen to myself is you're going to see some repeat. And I believe, and I've always believed that some repeat is always good. It's never enough to hear it once. It's hard to retain all the information. Obviously, Karen does it one way, I do another. So that's also a nice way to retain the information that you get from a flow from one master program to the next. Today, we're going to talk about really understanding the why of dental implants. We're going to learn the long-term, the short-term consequences of traditional dentistry, which I'll talk about tonight. A complete review of surgery. So all, because of strain of time, obviously we only have an hour. So I picked one surgery that I'll go from beginning to end and then just explain, just the step-by-step on how we do things. And then I did a little sum up of prosthetics. Again, we could do a full a day on prosthetics. So again, I try to homogenize things and make it simple to understand, keep it fresh and up to date, but also the information that you'll get tonight will also lead you towards going to the ADIA conference in September, where you'll get more in-depth information. So today it's really an intro to a lot of the different subjects that we're going to be talking about in September. I'm Vavi Bohbot. I do work for BioHorizons, so you will see I do have access to a lot, obviously, some of the images that I have at BioHorizons. So you will see BioHorizons. It's not about BioHorizons. I'm not trying to sell you the system, that's for sure. This is not what it's about tonight. Tonight it's about education, but that's what I have access to, so that's what you'll see. Whether it's BioHorizons or other implant companies, the process is, sorry, quite the same. But I'll go through the why we do what we do surgically and drilling wise, and then also prosthetically. I am the senior director for key accounts for BioHorizons, and I have been with BioHorizons for over 21 years. A little bit about myself: started in dentistry about 42 years ago. Started as a dental assistant. Loved what I did, and for me, surgery was really the core of really what I wanted to do. In a way, the more blood there was, the happier I was. It sounds gory, but that's what I loved. I loved surgery, and hopefully you do too if you're present here tonight with us. In 1980, I remember when I started, we had placed some implants on a patient that came in from a distant area, and it was a prosthodontist that had placed the implant. So that was my first exposure. And then 17, 18 years later, I needed to do something else. And so I worked for Dentsply Calc, where I worked for different distributors, and sold mostly impression material, composites, endomaterials, all that good stuff. Everybody knows what Dentsply Calc is. Lasted there for about 5 years, and then literally had a knock on the door. BioHorizons was looking for somebody, and I jumped, and I've been with them for the past 21 years. So not only I'm the senior director for the key accounts, but I also do a lot of training for all the new hired reps, and I absolutely love educating. I'll tell you my first experience as far as educating in implant dentistry. I was at Dr. Carl Mish's course, an intro, like a 101 course, and there were 100 dentists in front of me. I was obviously sitting in the back because I had just started working with BioHorizons. And I was sitting in the back, and I couldn't stop writing notes for like 3 days in a row. I was exposed to that. I'm very lucky to have been exposed to that as an assistant. And as I was taking notes the whole weekend, I realized that there were 100 dentists in front of me, but not one staff or team member that was sitting in the room. And obviously, they weren't there because it was a course given to dentists. But it frazzled me a little bit because I realized that even after 20 years of experience in the industry, I could stop writing, and couldn't even absorb fast enough the information that Dr. Carl Mish was sending our way for 3 days. And I was wondering, like, these dentists that are going back to their office, how are the team members going to capture or be passionate about what they've learned and what they want to implicate into their offices? And so right after that weekend, I got involved with ICOI, with ADIA. I myself wanted to have more knowledge, more education. I embarked in a voyage that has been and still is incredible. I started teaching. I first of all learned. I received my fellowship. And I encourage everyone to go through the process. I'm an assistant, but I still took the education or the certification program for the front desk, for coordinator, for hygienists, and obviously I did the one for assistant. And from taking those 4 levels, I was able to get my fellowship and was challenged to speak, to have a table clinic. And it was a very good training for me to be able to speak and to do some public speaking and training for the auxiliaries. So I'm very honored to be here this evening and to be able to share with you some of my knowledge. So as I mentioned, our programs are designed to be specific and obviously built upon. It's included for all team members. It's not just for one or the other. So anyone is very welcome, obviously, to these courses. We overlap of education, so everyone is on the same page, and we want to make sure, and that's why we've created this master program, so that when you go in September, you're not in the unknown. You'll be well advanced compared to the ones who have not attended these programs. Anything that we teach you is very easily implemented. The ideas, the tools we're very accessible also if there's something that you need extra from us as well. This is information from Tara. I believe that's the right phone number, Tara, because I did change it. I think that we didn't have the right number on the last presentation. So here's the phone number and the email. Tara is extraordinary. She's been with us for a very long time. She knows the ADIA inside out. And so anything that you need, please approach her and she'll be able to assist you with anything. This is about team training. This is about, and I'll say us because I do consider myself, yes, I work for BioHorizons, but I still consider myself as a team member. So I'll say us, as team members, we have to get engaged. I remember when my dentist back in the days used to go take a course on whatever they took. It wasn't as much as implants because we had just started getting introduced to that world. But whatever courses that they would go get, and I obviously did not go to the courses, they would come back and I would say, well, they'll calm down with their little toys and all the bells and whistles, and we'll get back to normal dentistry. But implant dentistry is not here to leave. And we are here to make sure that these patients, and I'll speak about that tonight, make sure that these patients do get these treatments. So we have to get involved and we have to get passionate about it. And we have to learn to speak to our patients in order for them to say yes to these treatments, or at least start thinking about it and start thinking of the consequences of if they don't do something about it. So why is it that we do it? And I know that Karen a few weeks ago spoke about some stats. So let me take it to another level also. 36 million Americans do not have any teeth. 120 million Americans are missing at least one tooth. And guess which one it was? Very often the first molar. These numbers are definitely going to grow in the next 2 decades. Edentalism, unfortunately, affects the aging population and also the economically disadvantaged population. And so I could tell you that I've lived those consequences with my mom. Unfortunately, I lost my mom in November, but for many years, I had to live with the fact that, you know, she had an upper denture, she had a lower partial, and it was a very, very difficult way of living. And I'll speak a little bit about it this evening as well. The geriatric population, the ratio of edentalism in individuals are 2 to 1. Approximately 23 million are completely edentulous and 12 million are edentulous at least in one arch. And the number of partially edentulous will definitely continue to increase in the next 15 years to 200 million individuals. So the amount of patients that are out there, and there's no way that anybody could say we don't have edentulous patients, or we don't know where they are, or they're not part of our clinic. Well, they are out there. The problem is that they just don't go to dentists because they remember the last thing that they had done, and we all know what it was. It's extractions, right? So the idea is to talk to all patients about what kind of treatments you do in your office, whether it's implant dentistry or anything else. There's something that we should get used to speaking about everything that we do as a service to the patient. The consequences of missing teeth, well, significant nutrition changes and also challenges, obesity, diabetes, coronary artery disease, and that is very much indicated not only for the single is not the same thing, but when we're starting to have partially edentulous, which is more than 1 or 2 teeth, and to fully edentulous, where consequences like this will happen in their life and in their health. Partials, dentures are short-term solutions to today's standards. It's not just partials. Implant dentistry is the most viable long-term solution for tooth replacement. And implant dentistry is the most cost-effective, and I'll show you that on this presentation, that it is more cost-effective than doing a partial or a denture. The social activity, obviously, of what is going on, especially to patients that are, retiring or have retired. Well, what do? They hopefully have put some money aside. They're hopefully traveling. They're hopefully getting together with their friends or, visiting grandchildren. Unfortunately, they will be going to funerals or celebrations of families, right? So, but what is around us all the time is food. And it is a big challenge to these patients who are partially or fully edentulous. They actually sit home and wonder, should I eat before going to event X, right? And I could tell you with my mom, she would call me before coming to my house and she would ask me, what is it that you're making tonight? And I would ask her what, and I knew why, but I would obviously push her and why are you asking that? And her problem is that she was worried about me serving something that she would not be able to eat. And so I always had to have a soup. I always had to have something soft for her to eat, because otherwise what everybody eats, she would not be able to eat with us. So it is a very big challenge for them. And unfortunately, what they end up eating is something that is sweet, cake, something that they're able to dunk in a coffee. And very often, if they really go for something that they really, really want to eat, very often you'll see leftover in their dish because they're just not able to masticate and eat the entire meal like everybody does with their natural teeth. So you don't want them, you want them to be eating this, right? Whether it's a salad, whether it's cooking together and enjoying their retirement together. Eating healthy food is a very important part of our longevity, right? So we want them to have a longer life. And so to have a longer life, you got to eat healthy, right? And how nice is that when they're able to have a piece of chicken or whatever they eat, whatever protein they eat, with a nice baked potato and a salad. That is the way that everybody wants to be and feel as we get older. You know, I want to be 80 or 90 and be able to eat a burger and a fries with my children or my grandchildren or my friends, right? Applesauce is great for dessert, but not for a meal. That's for sure. I wouldn't want that for the rest of my life. And unfortunately, a lot of that aging population end up with pureed food. And I saw that a lot with my mom, especially whenever she ended in the hospital, they would give her everything pureed. It was awful, and had absolutely no taste. They try to put protein powder in their applesauce in order for them to have some kind of protein. It's horrible to end up that way. So obviously, the burger is the better way to be. You don't want them to be frustrated with food, and that is what ends up happening, is that they are frustrated and they're not able to eat. They have a beautiful platter sitting right next to them, but they end up eating the soup because that's all they can handle. And so we definitely don't want that to happen to our patients or our loved ones. Seniors are active. They go dancing, they go golfing, they travel, they jog, they walk, they're part of walking, I don't know how to call them, but kind of marathons that I see a lot around town as well. They have fun, they do yoga, they do activities together, and they go swimming, or they bring their grandchildren swimming. And so could you imagine being in that generation and being worried about your denture flopping out, right? I know there's these videos and we giggle at it, but truly, truly in life, when they have to deal with something like that, it is very, very, very difficult. They take the adhesive with them at all times. They make sure that they have enough in their denture, and they repeat that several times a day to make sure that it's very secured in their mouth. So it is a big challenge for them to live with that, especially when they're active and they have a longer life. No matter what job you have in life, your success will be determined 5% by your academic credentials, 15% by your professional experience, and 80% by your communication skills. So, dentists could be the best at what they do, auxiliaries can be the best at what they do, but it's 80% of your communication that's going to make the difference. And so, learning to communicate with our patients, learning to actually even listen to our patients more than communicating, is a big, big part of making them go in the right direction. So let's dig into that right now. So by listening to them, what we're getting is how does that patient feel when we actually listen to them? Well, they feel important, right? And even if you're repeating the same question and you hear that same repeat of stories, of complaints, of things that they like and things that they don't like, right? That's happening in their mouths. Make it as if it's your first time listening, because when they know that they are special and they are listened to, and you really take the time, don't interrupt, you really take the time to listen to what they have to say and take notes of every little step, every little complaint, whether it's a positive or whether it's a negative, whatever it is, whether it's a positive or their challenges that they're dealing with their partial, their denture, their missing tooth, their pain, whatever it is, take a note of it and repeat it to them so that they understand that you're making them feel special and you actually listen to them, right? By repeating it to them, now they've, for them, confirmed, oh, she or he is actually listening to every word I just said. And by asking the right questions, you get a lot of information. So are we going to, make them say yes to the treatment today? Maybe yes, and maybe no. Maybe they're going to say, let me think about it. And maybe they're going to say, I need to get back home and speak to my loved ones and see if it's something that I'm going to move forward with. There's nothing wrong with that, but what you just did by asking the questions is by getting the information that you need to continue a conversation further down, when you meet them. So let's say you've had a nice discussion with them, you've asked them several questions, and off they go. They decided that they're going to think about it. Well, 3 months or 4 months or 6 months or even a year down the line, patients come back. You could take from the answers that you've received from your questions and get back on the conversation. Now we get back on the saddle, like we say. So get into your chart. Mrs. Smith, last time we talked, we spoke about, you had mentioned to me the things that you liked about your denture. You also mentioned to me the things that are challenging with your denture. And we didn't continue our conversation. And with your permission, I've been thinking a lot about you, and I've been thinking a lot about our conversation. And with your permission, I would really like to continue that conversation so that we can find a solution for you. Who's going to say no to that, right? Get to know the person before the patient. A lot of times we get into and I've been there, I've done that, where we get into a routine, we get into the op, we put our masks, we put our gloves, and we put their bibs, and we look into their mouths, and they just become a patient. They are not a person anymore to us. We kind of know a little bit about them, but we don't know a lot about them. And so by getting to know the person before the patient, it actually gives you access to things that you can talk about with the treatment planning that you are planning for that patient. So I'll give you an example of my mom, because it's a real example. My mom danced for a very long time. And so when she would go dancing with her upper denture and her lower partial, well, her upper denture was moving and her partial wasn't firm. So she had a hard time with it. And when she would go dancing, she would definitely put extra glue in there, adhesive, just to make sure that nothing would move. And she wasn't dancing like crazy, but for her, it was movement enough. And she would be in a social environment, so she wanted to make sure that nothing moved. And so when we went to her first appointment, assessment or consultation, that office didn't do such a great job. They spoke to her about what challenges they're assuming she's having, because they assume that everybody has the same challenges, and that's not a bad thing. And then they told her what kind of solutions they had for her, which was fine, but she had a hard time accepting them because she wasn't ready to listen yet. And that was it. And she looked at me, she goes, nope, not interested. I'm fine the way I am. I don't see an issue there. And yeah, I have a little bit of problem here and there, but I know how to solve it with my glue and I'm good to go. The next one actually started asking her questions about her as a person, not as a patient. What did she like to do? What does she do in her retirement? Does she do any activities? And so dancing came up in her activities, and the dentist or the auxiliary that was there with her says, oh my God, at your age, you go dancing. That's fantastic. Talk to me a little bit about it. And so my mom would get into the discussion without even realizing what she was talking about, which was great. And then the auxiliary asked her, are there any challenges with your denture and your partial when you dance? And my mom looked at me and looked at the lady that was in the consultation and said, well, yeah, a little bit, right? And then she got into the discussion of what her challenges were. And the solution was, well, what if we solved that issue and you wouldn't have to worry about that when you went dancing? And that's what made it, right? That's what made the difference. But if you went, put your gloves on and got into that comfort zone, you wouldn't know that my mom went dancing, and you wouldn't know how to tackle that conversation with my mom for her to say, didn't think about that aspect of it. And let's talk a little bit more about it, kind of thing. So get off that patient. Yes, we are going to put our masks and our gloves and get into the mouth and look what's going on. Obviously, that's what we do day in, day out. But for the beginning, get to know your patient first, because those are going to get real great tools for you to have this discussion of wherever you want to take them, whether it's whitening. Obviously, tonight we're talking about implants, but whatever you want to take them, whether it's veneers or a whole makeover, that get to know your patient first. So, how do we change those challenges that we have with our patients? Well, the fear of loss is a powerful motivator. And understand that these patients, if we're talking about now fully edentulous patients, well, these patients had their last appointment, which was the most scary appointment that they had, was a full mouth extraction, right? Maybe they had it one at a time and they continued adding teeth to their partial and they ended up being edentulous, obviously, or they had a full mouth extraction. Whatever it is, something took them there. And for them, a dental chair is a very traumatic place to be at. So understand that about a patient. But let me flip it the other way now. A patient that has all their teeth and is losing one tooth. Well, the fear of loss is very powerful. It's a great way to speak to the patient on the loss of the bone. I call it melting bone, right? The bone is going to melt away if we don't put something back in it, or you're going to end up with a defect if we don't do anything about it. Nobody wants to have a defect in their body. And so the language that we use will make a patient react a little bit better. You have to be comfortable with it, as obviously, and choose your words. Those are my words. It doesn't mean that you're going to be comfortable with that, but choose your words that are going to make them react. We're just going to remove your tooth and everything will be okay. No, everything will not be okay, because when we remove a tooth, bone starts to resorb. And so we have to do something about it. We cannot leave a defect there. We should fix it. We should repair it. And how do we do that? With socket grafting or an immediate implant, right? So let's go a little bit to the basics. Let's go back a little bit. So the amount of bone loss in the first year after tooth loss is almost 10 times greater than the following years. And it's going to keep going if we don't do anything about it, right? So it's important to react the day that we extract, or at least let's take that single tooth extraction, or take somebody who is partially or fully edentulous and really speak to them about the consequences of, if they keep going, what's going to happen and what kind of consequences are going to happen to their mouth. The bone loss is going to keep going, and it won't stop until we anchor something into the bone. So whether it's a tooth, obviously that's gone, or an implant that's going to stimulate that bone. So let's look at the pros and cons. And I know that Karen touched base on that. I'm going to dig a little bit deeper, but I think it's good to have a repeat on that. I was thinking about it. I said, should I repeat it? And I said, yeah, I'm going to repeat it, because I think those are the biggest challenge that we have, is case acceptance, is how do we discuss it with the patient so that the patient really benefits of the conversation we're having with them when it comes to pros and cons of whether it's you're extracting one tooth or doing a bridge, or you're talking to a patient who has a partial, or you're talking to a patient that is fully edentulous. So let's look at the pros and cons. And how do I approach it? Well, the way I approach it with patients, I don't want to make them feel that the decision that they made of all these years, whether they did a bridge on one side 10, 15, 20 years ago, and now they're losing a tooth on the other side, and they've decided, I'm going to do the same treatment I had here. It kind of went well. It wasn't that bad. I'm going to repeat it here. So I want to make sure that we stay respectful with the patient and have a educated discussion with them, but without making them feel that 20 years ago they made the wrong decision, right? And then when it comes to partially or fully edentulous patients, that's even a higher conversation, because not only is intimidating for the auxiliaries, because now you're proposing a treatment that can go from $10,000 to $25,000 easily, and even more, right? So that could be intimidating for us, but take away the intimidation, take away the money. It has nothing to do with money. It has to do with getting the patient the right treatment so that they're able to have that longevity that they're looking for, which we're all looking for, right? So let's look at the bridge itself. So what are the positive signs of a bridge? When you're asking the patient, you have a bridge here, Mrs. Smith. What went well with your bridge? And the first thing they're going to say is, I didn't have a surgery. It went actually really well because I've had surgeries, I've had teeth extracted, and I really don't. I get scared when it comes to that, but the bridge was really easy. It's aesthetic, it looks good, right? To them, it looks great, and it does look good, right? It's fast to completion. They had it quickly within a week or two. It was cemented in their mouth, and off they went. It's stable. They can eat on it. They can function on it properly. They could smile with it. So not an issue there. And the insurance covers it. Bummer, but that's what it is, right? We have to battle with the insurance. So the insurance does cover it, right? And it does cover it even, I believe, every 10 years, they'll cover it again, right? So that is a challenge. What about partials, Mrs. Smith? Let's talk to somebody else. Mrs. Mary, let's say. How are you doing with your partials? And explain to me, I just want to hear what's going well with your partial. And they're going to be a little bit frazzled when you ask them that question, because a lot of times they'll complain, right? Our first sentence very often is, what can we do for you today? And then they'll throw up all sorts of complaints, right? But let's change that atmosphere a little bit in the office, and let's ask them, what's going well with your smile? And they're going to ask you, well, that's interesting. Nobody has ever asked me that question. And I'll give you a pointer. It's very good to ask that question, because if you are redoing something, whether it's a partial or a denture or a bridge or whatever you're redoing, and obviously you're charging for it, but they're due to have it redone. It's good to know what they do like about their partial or their denture or their bridge, because I would tell them, whenever you tell us what you like, is things that we can repeat. So whether it's the color, the shade, the shape of the tooth, whatever it is that you like about it, we're going to take notes of it and we're going to make sure to repeat it. And then we'll discuss the things that are challenging or that you don't like as much about it. And hopefully we'll be able to redo it and find ways to not repeat the things that you don't like, right? So the things that they like about their partial, you're going to see that it's kind of the same thing. Not much of a surgery, really. It's aesthetic when they redo the partial. I'm not talking about when they had it for the first time. I'm talking about redoing their partials now, right? No surgery. It's aesthetics. It's fast to completion. It's stable for them, right? And the insurance covers it. So same thing again. And I could repeat the same thing. And I know, dentures, you're going to say, well, it's not that stable. But for them, it kind of works. They put a little bit of glue. They're happy at the end of the day. They get beautiful teeth and off they go, right? So, and they know what they know, right? They've lived with it. Maybe their mother had dentures and their grandmother had dentures, or father, right? And it's something that they're used to. So they don't know what they don't know about implants. It's for us to educate them on that. Well, let's ask them now, what are the challenges? Or if we had to redo the partial, the bridge, or the denture, what would they want to change about it, right? Or what's going on that we can make better for them, right? And so in the bridge, a lot of times they'll say, well, it doesn't look as good long term. I could see that after a few years, a little bit of gum is not there anymore, or I've got food stuck in there, or there's a little bit of yellow that shows, or my teeth are getting yellow, but that thing stays always the same color, so it doesn't look good, right? So aesthetically it doesn't look good anymore. There's cavities. We had to fix cavities. So I had to put more money. I had to invest more money, or spend more money. It's not really investing, spend more money to make sure that the bridge still worked for me, right? They get a lot of perio issues, right? And you're going to say, well, because they don't floss. But it's a big challenge to floss under a bridge. I don't know if any of you have had a bridge. I know I haven't, but I know that it's a very big challenge when I used to teach patients how to use the floss threader and get underneath there, or even use a water pick. We just send them to the pharmacy and tell them to buy or Walmart and tell them to buy a water pick. But have you ever really taught a patient on the counter near a sink how to use a water pick? I'll tell you, I did that with my mom, and I was sprayed on. She was sprayed on. Obviously, we laughed about it, but it wasn't as easy as you think it is for a patient, and I don't care what age they are, to be able to press on something and hold their lip and make sure that they're not sprayed all over the place. It's not as easy as we think it is. And as they get older, obviously dexterity becomes a challenge. Perio issues is a big issue with a bridge, and then they end up doing a root canal, right? Because of the decay. Most of the bridges end up with a root canal. Hygiene challenges is, as we said, and when I ask them, when they tell me that I have a hard time flossing, I dig a little bit deeper into it. I want to really understand what are their. We know what the challenges are, but the more they talk about it, the more they realize that it is a challenge and that they can do that. When we talk about implants, it would be such an easier way to treat this empty space that they have, right? The missing tooth. We do trim vital teeth down, and you're going to say, well, it's an MODBL. Well, even if it's an MODBL, it's still a vital tooth. And we trim them down and we make them even more vulnerable than they've been from the beginning. So yeah, it's not the best thing. It's not the best treatment. Food retention underneath that pontic, very often, especially in the anterior regions, food, spinach, seed from a raspberry or chia seeds will get stuck in there for sure. They develop a bad breath. They become very sensitive because of the gum recessions. And they do cost to redo, whether it's to redo, or now we're doing a root canal, or we're doing maybe a gum graft, or we're fixing a decay that's underneath there, right? And at the end of the day, we didn't solve the issue. There's still bone loss underneath that pontic. And even if you say, well, they should floss more to prevent all that, it doesn't matter. They're actually, the problem of all this is not because you didn't do it right or the patient isn't flossing. It's because we're not stimulating that missing tooth area. And because we're not stimulating it, the bone starts to melt away. And what happens with the gum? The gum is going to follow the bone. That's what always happens. And so then everything gets exposed. The tooth gets exposed, everything gets exposed, right? What about a partial? Poor long-term aesthetics as well. Multiple revisions. They do come back for little nicks and repairs. The hook broke, all sorts of things that can happen with a partial. They do decay, especially underneath that hook. There's abrasion underneath that hook, and I'll get into more of that as I get down to the last point of for the partials. The hooks are visible. We try to make them as aesthetic and as back as we can, but at the end of the day, you know, they do have to hook on something, so they do become visible, unfortunately. So it's not as aesthetic. The clasps do break, and very often when you're on vacation or they're on vacation, they do have to use adhesive. The anchored tooth is a problem. It does become sensitive because there is that abrasion that happens. They do end up with very high plaque count. There is food retention under that partial. Now they're sitting in a business meeting or at a party, and they have food that's stuck underneath their partial. What do you think they do? They don't go in the bathroom and rinse it. That's not what they do. They get stuck with it. And they wait till they get home to get rid of the food that's underneath their partial. Meanwhile, the whole evening or the whole day, this thing is thumping underneath because guess what? There's a sore that started to create under that partial. Here we go. The sores are there. Now, you went dancing, you had a little sore underneath in your foot. Would you take off your shoe? Absolutely not, because you're worried you won't be able to put it back on, right? You go home, you take off your shoe. It's like, thank God I could take off my shoe. Well, that sore is going to grow overnight. Now the next day comes. Can you put your shoe back on? That's what happens to them. They can't put their partials back on because that sore is there, and it's so sensitive for them to put that partial back. And all that, it's not because you didn't do it right. And it's not because you didn't take care of it properly. It's because that bone loss happens the day you deliver the partial. They leave the office and that bone starts to melt away. And now what? The bone melts away, the tissue follows it, and that partial stops to fit properly, right? Go a little bit faster than that because it's a repeat again. What's going on with the denture? Poor long-term aesthetics, multiple revisions. They have to do relines. Let's talk about relines. Why do we do relines? Well, we do relines because they're losing bone. The bone is melting away. The tissue is following it. Now that denture is not sitting properly, they want to come back and readjust all that to make sure that it's snug again. Well, every time you do a reline, what you're doing, and be very conscious of it, what you're doing is replacing the little microns of bone that just melted away within the first few weeks or months. And it's just going to keep going. And my advice to you, if they come for the first reline, obviously we want to be respectful and do it for them. And very often we don't even charge them for a reline, right? So it's a lot of chair time, lost chair time, and revenue for the office. They come the second time, we kind of huff and puff about it, but we still do it. Well, by the third time, I think we need to start having a discussion with the patient and making them understand that every time we do a reline, it's because they've lost more bone. And in order for them to stop losing bone, we have to do something about it, because that denture is not going to save the bone for them, right? They break for sure. The teeth fall off. They do get electric shocks. Now that depends on how much bone loss they've had or how long they've been wearing this denture. But as they go closer and closer to the mental foramen, they will have electric shocks underneath their tongue. They are unstable. They're loose. They have to use a lot of adhesive. The taste alterations are gone. The food retention underneath the denture is very painful. They do get acid reflux because they're hungry, they want to eat, but unfortunately they don't bite into a very small size. So they eat and they swallow in big pieces, and they do end up having a lot of heartburn or acid reflux. When they take off their upper and lower denture, because of all the bone resorption, they become very wrinkled, and you'll see a picture of that. They do have a lot of sores, and unfortunately, they have a hard time wearing their denture when they have these sores. And they have a limited food choice because they can't eat what we eat, that's for sure. Loss of lip line, and all of that again. It's not because they're not taking care of the denture properly or you did it wrong. It's because the bone loss happens. And the minute you deliver that beautiful denture that snaps in, everything is great. You've taken the time to take an impression. You've taken the time to discuss it with the lab techs to make sure that everything was done properly. The teeth was placed properly, the color, the shade, the shape, all the stuff that you want to create to make sure that your patient is satisfied with the treatment that you're delivering to them. And then they leave the office, and a week or 2 or 3, they come back and the complaints start to happen. And so we're delivering a treatment, and I'm not saying not to do it. That's not my message today, but they have to be aware of what they've signed in for. And by doing the pros, first and foremost, asking them what's going well, and doing the cons and going through what are their challenges and discussing with them that a lot of these challenges are not going to be able to go away if we repeat the same treatment. So let me ask you a question. Let me go to the partial. If we redid a partial for the patient, can we guarantee them that they'll never have decay under that hook? Can't guarantee it. Can we guarantee that they'll never have food retention under the partial? We can't guarantee that as well. Can we guarantee them that they'll never have a sore under the partial? We can't do that as well. So we could see that all these treatments, and I can do every one of them, all these treatments have a clinical challenge, have a clinical consequence that is absolutely going to happen if we don't treat them with implant dentistry. With implant dentistry, you'll be able to remove, I would say, at least 95% of these issues. So why not implant dentistry, right? And it is, at the end of the day, for all of them, a short-term solution. Patients are not happy with removable prosthesis. I would challenge you, and if you've been in Karen and I's courses for over the years, we challenge everybody to taste the adhesive, and I think it's a must. The day that you taste the adhesive, you will understand, and you'll be able to discuss on a different level with your patients on the detriments of putting this adhesive 2 to 3 to 4, maybe sometimes 6 times a day to make sure that everything stays stable. So I would challenge you as a team, bring some adhesive at the lunchroom on a piece of gauze. Just put a little bit on your tongue so that you understand what your patients go through. And obviously a nice little Hershey kiss after would be nice because it tastes awful. Sorry about that. And you know, we call it a denture. I actually call it a prosthesis. I think a denture is a pretty word. Everybody gets away with it, but it is a prosthesis. And whether you have a missing limb, this is kind of the same thing. I believe that at the end of the day, when you're in your own private room, house by yourself or apartment, there is a feeling of, oh, I just need to take this thing off because it's big, it's clumsy, it moves around, it tastes awful, I can't eat with it, and they just want to remove it, right? But I'll tell you something, my mom never removed it. My dad, I don't even think knew that she had a denture and a lower partial. I was the only one because I was from the industry. And it is a man-made body part. So it is a prosthesis and it's not pleasant. And like I said, we're going to keep having resorption. So, you know, when you take a denture and you put it up in the light and you can see the light and transparency, well, it's somebody who just probably was introduced to a denture. But then you take these dentures that you put it in the light and there's no shining through at all through it. Well, I could tell you that this is a patient that's had a denture for a very, very, very long time. And the thicker it is, you conclude, the more bone loss has happened in their mouth. And all they think about is food. They're hungry all the time, but unfortunately, all the food that they're eating doesn't satisfy their hunger, unfortunately. Patient is willing to accept unpleasant taste, need for reoccurrent application, inconsistent fit, embarrassing circumstances, and continued expenses, and all they want is retention. Can that thing just stay in my mouth? That's all I want. And I know Karen talked a little bit about that. It is I live in Montreal, and there is a specialty in Canada that we have. It's called denturists, and denturists are not dentists. They're not auxiliaries. They are a profession that only take care of prosthesis. That's all they do. They work on the gum or on the implants. And so they did a little study in Montreal, and they asked questions to the patients on the satisfaction of the different treatments that they had in their mouth. And two out of 10 were satisfied with their lower denture, so not a very good treatment. But it jumped very quickly, 6 out of 10 for 2 implants. So 2 is better than nothing. I would say that, you know, even if, you know, you say patients can't afford a treatment, at least offer them 2 and position them in the right place for them to be able to have access to another 2 along the way. And obviously, as I move on, the stability scale is much higher for the patient. All right. Any questions, Tara, before I move to surgical? I've got about 10, 15 minutes still left.
Nope, doesn't look like it.
Okay. All right, let's talk surgical. I'm going to flow through this, but if there's any questions, obviously, I'd love to hear anyone bring up any questions or pearls. I'd love to hear that as well. So, you know, when we talk about surgery and implant dentistry, the idea is to increment 0.5 millimeters at a time. And that is because we don't want to traumatize the bone. We don't want to overheat the bone as well. So we want to make sure that we do it in a very easy, slow way until we get to the osteotomy that we need to get to be able to place the implant. And I know that I believe that when you go in September, you'll be able to have a hands-on at placing a dummy implant. So hopefully that will work out and you'll be able to do that as well. So we usually take the first drill, whether it's a 2.0 or 1.5, depending on the system that you work, we take the first one, and that's the workhorse. That's the one that's going to initiate the first osteotomy. Once we initiated the osteotomy, we want to take a paralleling pin. And this is obviously freehand. I'm not talking about guided. That would be more of an advanced thing that we would do. So you take a paralleling pin, and the pin will actually, indicate your parallelism, right? If you have to correct it, then you would use this drill that's called a liniment drill. And a liniment drill is a side cutting drill that could realign you and realign the next osteotomies. And then as you move forward, you increase your osteotomies, and you want to make sure that your drill bits are collecting, obviously, this bone very often. And you want the bone to be pinkish red. You don't want it to be white, because if it's white, then maybe your drill is done. Or maybe the dentists are dragging a little bit too long in the osteotomy. So watch your drills. You want to make sure that you change them every 12 to 20 osteotomies, depending on the bone density you work at. And so you continue the osteotomy, you continue checking, this is your second chance, checking your parallelism, making sure that you're in the right position, and make sure that you put a floss through these paralleling pins, because I have seen a lot of them going down the throat. So make sure that you have that for safety reasons. And then you keep going on your osteotomies as it's mentioned here. And then you just check it for the last time. You're not going to change anything at this point, but very often a lot of dentists will take a PA just to make sure that they're oriented properly and at the right depth as well, before placing the implant. Changing the program of the motor, whether it's a 30 or 35, very often most companies are in that range of Newton centimeters to place your implant in the osteotomy that you just started. And then you take your driver, your implant driver, and you connect it to the implant. So obviously connect the driver to the handpiece at first, open up your implant pack, drop your implant. That implant is green because it's called a dummy implant. It's not a real implant. I use it for training purposes. And then you unscrew the cap, snap the driver into the implant, and carry the implant into the osteotomy. Once the implant is placed in the osteotomy, you would use a wrench just to wrench it in place, because you can't place the implant at the perfect position with the handpiece. It's a little bit too fast. So very often, and also to get the feel of the initial stability of the implant, very often your dentist will take a wrench or torque wrench, and they will wrench it in place and feel the stability of the implant once they're satisfied with the height. So here we are. You would take the wrench and the implant driver and drive it into the bone. And then at the end, you could put a cover screw, cover it up, and that would be considered a 2-stage surgery, or put a healing abutment and call it a single-stage surgery, where the patient would come back at that point and then start doing the prosthetics after that. So here is a case, fully edentulous, been edentulous for a very long time. I was there in that surgery. They did a full incision, and you could see, I don't know if you see my pointer, but you could see a tie back. We use silk suture to tie back the lingual part so that it's not in the way. And I love when dentists do that, because it's not in my way as an assisting. And then I don't know if you could appreciate this picture, but it is a very knife edge bone, just because of all the resorption that's happened with that denture. So we level down the bone, and we make sure that we have at least 7 millimeters of width buccolingual in order to place an implant. You want at least 1.5 millimeters of all regions, especially buccolingual, when we're placing implants. And in that stage, they've decided to do a 2-stage surgery where they put healing abutments, covered it up, and then they would come back 4 months down the line and expose the implants, put, whether it's locators or healing abutment, whatever the next stage is. And those are the implants that were placed. So if we go from left to right, then the first one would be a cover screw, which is a 2-stage surgery. The healing abutment is a single-stage surgery. And then kind of a loaded, especially in the aesthetic zone. I mean, if I'm your patient and I have an anterior that we have to place an implant, I'm not going to walk around with a healing abutment or nothing there at all. I'm a public speaker. I'm with people a lot. So very often your patients will want some temporization, obviously under occlusion. It's just for aesthetic. It's not for biting nor for eating. Let's go to prosthetics. So very quickly, you've got an open tray, closed tray. This is an implant level impression technique, and they'll take an impression, whether it's an open tray, a snap coping. There's different ways of taking an impression, which we don't have time to get into tonight. But at the end of the day, the idea is to have your implant, your parts and pieces that are on top, and then the crown. So whether the abutment and the crown will be one piece and get screwed onto the implant, or the abutment gets screwed on the implant and the crown gets cemented. Whichever way your dentist want to do it is very successful. You've got your analog as well, and the analog is a replica of the implant. The bottom part does not really make any difference. It's the top part. What did you take an impression of is what the analog is. The lab technicians have to have that part because they don't have the patient in the chair with them, but they have to have the analog that will indicate now, because of the impression you took, the position of the hex, if that's the case, or the position of the implant, so that they now can prepare and create the crown on top of that. And it would kind of look like, not kind of, it would look like that once they would pour that impression that you took. If we look at the world today, we very rarely will take an impression in the mouth. Very often we'll take a CAD CAM, right? We're going to put we got a scan body on the implant, and we'll scan the scan body. And once that's scanned, it actually is getting into the software, right? So we have to have the software to scan it, whether it's iOS, whatever iOS system you have. And then we send that scan to a milling customer or milling system, whether it's your lab technician that has communication with a milling center. And from there, they would take a bulk titanium, I call it a bullet, and they would put it into these machines that will actually scale down those abutments and deliver to the technician in order for them to create the crown that goes on top of that. So these big mega machines do these little titanium abutments, which is quite impressive. So here it is. And at the end of the day, they could actually, it's just like a puck, and they could take it and they do also the zirconia part of it as well. And so if you look at that picture on the right, you have that milled abutment, patient-specific milled abutment. And then on top of that, they actually milled that zirconia, which will be merged together and delivered to your lab, which, because it's a milling company, they deliver to your lab, and your lab would polish it and stain it and do whatever you need them to do in order to screw that onto the patient and onto the implant. And then you have also multi-units, which is what we do today, all on X, whether it's 4, 5, 6 implants, whatever the case may be. Patients are very satisfied with something like that. It's just having their natural teeth back in place. And then the locator system, which is an overdenture traditionally done, which would be a snap-on, snap-off. I have a picture of 2. You can go 4, you can go 6. Very often it's 2 to 4. But patients are also very happy with that. They snap it in, they snap it off. It's nothing that moves around. They're very happy with it. They don't have to use adhesive anymore. So a lot of the challenges that they have completely disappear. Don't take a patient that is, we look at this and we know that there's a lot of issues going on here, and we know that there's decay and there's a broken tooth and there's root canal. There's a lot of things going on here. But take a picture, take a scan like that and sit down with the patient instead of beating them up because they know it's coming. Why don't you compliment them? Why don't we compliment them and say, you know what, Mr. Robert, thank you so much for not only investing in all your whatever you've been doing all these years, but to hold on to those teeth. And because you've held on to these teeth all these years, we have all the bone in the world to be able to help you today. Very often patients who lose all this teeth that you've been hanging on to, we don't have many solutions, and it's a big challenge for them. But because you've held all these teeth, we have all the bone in the world, and you're really one of the lucky ones. And so when you talk to a patient like that, all of a sudden the mood changes and they're ready to listen. So don't take them from that. Obviously, it's not the same patient, but don't take them from that. Extract everything, do nothing about it, and let them end up there many years later. put a couple of implants, put 4 implants, do a bar, don't do a bar. I don't care what we do, but do something to prevent that bone from melting away. Let's take just 1 more minute. This beautiful patient, this case was given to me by Dr. Justin Moody. He's one of our speakers in Phoenix, Arizona. And here's a patient who you could see the top is gone for many, many, many years. But you could see that she's held on to those teeth. She's invested a lot of money. There's crowns, there's a lot of endo going on there, but you could see, I mean, we're not dentists, but you could see how much perio issues are going on, and decay and fractures and loss of a crown. And there's a lot of things going on in her mouth, but she held on to them. And because she held on to them, we have all the bone in the world to be able to service her today. So obviously they obviously have a positive discussion. By having a positive discussion, the patient feels encouraged to actually have the treatment in your office. So here she is, and look at her eyes, look at the color of her eyes, and look at the texture of her skin and the sadness in her eyes. And so, you know, she did hold on to those teeth, but unfortunately those teeth have to go. So they did a full extraction, but they didn't let her go like that. They put 4 implants, and they put a little one in the back there to create a great AP spread so she could have a full denture in her mouth. And now look at her smile. What a different person, right? Because we gave her something that she could actually enjoy her life and hopefully have a longer life with it. So it is showtime. You do have to get in the office and focus on your patients. If you're not tired at the end of the day, not only physically, but mentally, I think we did it wrong. In order for us to really focus on our patients, we have to put aside all our family things. We have to put aside a lot of things. We have to put aside all the stuff that goes on in the office. The main focus is not your dentist. The main focus is the patient, right? And the more we listen to them, the more we'll have a yes at the end of the day. And so if I ask you how many patients you receive in implant care, well, a lot of times offices have 2 hygienists in their offices. And very often every hygienist sees about 10 patients a day. And I just do it random. Sometimes it's 7, sometimes it's 10, whatever it is, right? How many patients per hygienist? And so at the end of the day, it's 20 patients per day, which makes it about 100 patients per week and about 400 patients per month. And it's 4,800 patients per year. Now, I know that not all patients need an implant, but it is a lot of patients going through the office. And so my question is now, how many patients say yes to your cases? So let's look just at an overdenture. If let's say we charged $10,000 for an overdenture and a fix is $25,000. And again, I just took numbers, right? And we do 2 a week. And per month, we do 8 overdentures per month. Well, 8 overdentures per month at 10,000 times 8 times 12 months is close to $1 million. And I know it's not about the money, but the return on investment, not only monetarily, but satisfaction of the patient, instead of them coming back and us grinding down and doing more relines and trying to figure out a way to make them happy, which you won't. This is the way to make them happy, right? And if you look at fixed, if you do 4 a month, if you do 1 a week, look at where we can go, right? It's crazy. And alone, we can't do this. It's together that we can do so much. So it's not about just the dentist. It's not about the auxiliaries or the front or the assistant or the hygienist or the patient. It's a team job that we need to do together in order to make implant dentistry a success in your office. So I hope you enjoyed this evening. My email address is here. Please reach out if you have any questions, any pearls. I always learn from everybody that attends these kind of webinars, and I look forward to our next one, which will be digging more into aseptic setup. And I probably will not do more of the full setup. I'm going to do like a very shortened setup because I see that more and more dentists are doing that today. And we'll get into all sorts of pearls and do's and don'ts. So looking forward to seeing everybody in a few weeks.
Thank you very much, Vavi, and thank you everybody for being here tonight. 3 weeks from tonight, as Vavi just said, we will have our next webinar. And I'm sure there will be many, many more pearls to learn from that one as there were in this one. So thank you again, Vavi. We appreciate your time.
Thank you.
And everyone for being here. and we will see you next time.
Have a good
Bye.
evening.
Thanks.
Bye.